talk about diabetes. We're in Tennessee. We have a pretty high incidence of diabetes. We all know somebody who has diabetes, or we are diabetic ourselves. There's a 25% chance of workplace injury if you have diabetes versus 20% if you don't. Diabetic workers take 62 days off work versus 43 for non-diabetics. You're going to get this, I'm not going to read it all to you, but part of the problem with diabetes is the impaired circulation, the inability to heal correctly, the bones that don't heal like they should, nerve damage, chronic hearing loss, things that can come up and are much more prevalent in those who have diabetes. Diabetics have delayed wound healing, and I have a little gross story about that one. We have in Kingsport, I'm not in Kingsport anymore, you know, the other Kingsport people are here now, and they're much better at it than I ever thought I would be. But we had a gentleman who worked on a garbage truck, and he fell off the back and caught his ankle in his boot and pulled, and it was kind of run over. Luckily, his boot stayed on because what he did in effect was deglove his foot. He was diabetic. It never healed. Until the day he died, he had an open wound on his heel. It never healed. He was unable to come back to work. He worked probably for 2 or 3 more years limping. He was a supervisor, so he didn't have to get out there on the garbage truck as much. But think about that. One of your people that you care about has an open wound on their foot for the rest of their life simply because they were diabetic. It would have healed had he not been diabetic. Diabetic issues can relate in workers' comp and liability claims. You don't think about this, but as diabetes progresses, vision reduces. So you have people out there in their vehicles all day long. Your police officers, your fire trucks, your garbage trucks, your school buses. These folks may not realize that their vision is lessened, and that can cause automobile accidents. They have chronic foot issues that can cause their bones to break. Another Kingsport story had a guy in fleet maintenance who broke his foot. It never healed, but when it started to heal, the bones started growing more and more and more and more and more. And he got one that I can't pronounce here, the diabetic neuropathy. But basically, it was his bones were just never good on his foot, and he couldn't work anymore because he was a fleet mechanic. He couldn't lean over the hood of a vehicle anymore. This is important stuff. Now, those of you that have HR, who has HR? Okay, we can't test, don't know who has diabetes when we come in, nor should we. But we need to be aware of it, especially if you have a health insurance program. Because you need to have sound diabetic management programs in your health insurance program to help these people stay healthy so that they can stay at work. Let's talk about obesity. Again, we're in Tennessee. We're a little chubby in Tennessee. I myself am classified as overweight. I have in my lifetime been classified as obese. So think about what we consider to be normal from a medical perspective is different. Someone with a BMI of 25 to 30, which is an overweight person, they are 12% more likely to take off sick. And they're 12% more likely they are off work 12% more than others. With those that are considered to be obese, 30 to 35, 36% more likely to take off, and they're off 38% longer. And you see these numbers go up the larger the person gets. This is not always the person's fault. Obesity is sometimes a medical condition. It is sometimes a brain condition. It's sometimes a habit condition. But a lot of these can be treated, and if you can have sound, effective programs in place to help these folks, then you can not only lower your health insurance costs, you can reduce potentially your workers' compensation costs from lost time and things like that. and you can help your employees. Obese patients are 5 times more likely to have knee and ankle injuries, have a knee replacement. 3 times more likely to have a hip replacement. How many of you had a knee replacement come up as a workers' comp because that one last thing that they did that blew it out happened to work? Yeah. So they have, obese patients have 33% more anxiety, 50% more substance abuse. Some of us have chocolate abuse. Some more depression and more eating disorders. Again, not everybody who is obese just because they sit around and eat bonbons. That is not what happens to people. The way they think about food, their reaction to food, the more studies that they're doing about obesity and diabetes, the more they are finding out that it is as much mental as it is anything else. And there are some actual physical, mental, cognitive connections that are misfiring. And those can be corrected. Duke University study says that obese workers had 183.63 lost work days per year per 100 workers versus 14 for non-obese workers. Think about that. Who are your high hitters on your lost time? Who has worn out all of their PTO or their sick leave? They may really be sick, but it could be that these are what we call comorbidities. There are many things that go hand in hand in hand. So it strains the joints like we talked about, it creates mobility issues, results in more slips and falls. I am not, and I'm old, and that's part of it, but I'm not as limber as I used to be. So I know that if I get, and God gave me the center of gravity so that there would be no tornado that could blow me away, that if I get all this honey moving in one direction, I'm gonna fall down. I don't have enough strength to pull it back. That's a real thing. It creates fatigue. It's exhausting to carry around. It's exhausting to have all of these other additional things like chronic inflammation that comes with it. So, do any of your employees work long hours? Any of your employees perform repetitive motions? Any of them have emergency, stressful, jump to it and take care of it right now things? Like, oh, there's the fire alarm. Police, you've got to go get that child shooter at the school. Those create heart stresses, stress responses that can be linked and can be made worse by these other conditions. The Tennessee Workers' Compensation Act, it does it does permit a proportionate. Okay, I'm just gonna stop. Rewind. It permits a proportionate, but it has public safety presumptions. We all know this. So and I don't know about you guys, I used to have some public safety folks that were maybe not as healthy as they could have been. And there wasn't a whole lot we could do about it. I mean, you can't mandate that somebody be physically fit to have these jobs, so at least you could have been, and I'm not up on the law screen. But what are you going to do when that morbidly obese police officer tries to get out of his car and chase a perpetrator down the road or down the hill and falls and breaks it? What are you going to do when PTSD, but heart disease? What about the firefighter? That the alarm goes off and they get out there and it's hot and they're in that burning building and they've got the hose and they're obese and they have a heart attack. The presumption is it's yours. But no matter the fact that they were a 3-pack-a-day smoker and that they were 50 pounds overweight. Oh, I need to get there. I forgot one comment I was going to make. Some diabetes and obesity medications may interact with some of the medications to treat some of these. I'm sorry, you all can't see me because I'm standing right in front of you. GLP-1's that we're going to talk about here in a minute. There are studies show that they have the potential to improve some of these conditions. But they're not long-term over here studies. So I want to preface all of this by saying we are not here to say GLP-1s are good or GLP-1s are bad. We're here to say GLP-1s are here to stay. And what should you do to evaluate whether or not you should cover GLP-1s, and in what manner should you cover GLP-1s, and how do you incorporate them into your programs? There are they show no direct interaction with PTSD or HIV medications. Okay, what are these? Glucagon, night peptide 1. It's a hormone that's produced in your gut that helps you digest food and regulate your blood sugar and do all those things. It's a naturally occurring hormone. It stimulates the release of insulin. Diabetics have a problem with releasing insulin. That's why they need insulin replacement. The role in diabetes is there to control the blood sugar level. Insulin helps lower the blood sugar. That's why people take insulin. That's why we have laws now that say that you can't charge them thousands of dollars for insulin that they could 5 years ago, because it's important for the care and maintenance of a diabetic. Maintenance being the key. All of the diabetic treatments historically have been to maintain a positive blood sugar level. They have all been, we're going to keep you on metformin, you're going to be on it for the rest of your life, and your blood sugar will stay where it needs to be. But it is a maintenance medication, you're taking it forever. Done correctly, some of the medications beyond GLP-1s can be used in conjunction with other therapies and can cause diabetes to go in remission in some people. Now, wouldn't that be cool? No more shots. You know, as long as you change the brain and you know that you're eating correctly and you're eating healthy, you can maintain your own diabetes. You're not diabetic anymore. These are the ones that we're talking about, which you know, Ozempic, Wegovy, Trulicity, do they work for weight loss? Sure they do. Do they work for diabetes? Absolutely they do. The problem is, do they work long term? And without the supporting sides that Mark is going to talk more about, without the support of programs that can help the person know how to change their life, when they stop taking the GLP-1, the weight comes back on. When they stop taking the GLP-1, the A1C goes back up. The blood sugar level goes back up. Okay, now this is just something that we put together to show you the cost, and this is a 2-year-old chart, just so you know, the cost of treatment for obesity. If you come to the right, that is the most effective. Those toward the right are more effective. Toward the top, more expensive. So toward the bottom, less expensive. Toward the left, less effective. The most effective thing is bariatric surgery. Studies will show you that for obesity, long term, the most effective is bariatric surgery. It's the most expensive at $38,000, but at that time it's probably closer to $50,000 now. But keep in mind, that's a one-time cost. Zepbound was, of the GLP-1s, the most effective for weight loss and closer to the least effective in cost at a mere $12,000. So keep in mind that that's money, $12,000. Now that's a year. That's a year. I'm sorry. I was having another moment. Okay, Mark is going to tell you about pharmacy, and this is parallelly important.
The first thing your health plan thinks about, and thank you for your time today, I'm talking about drugs, even legal ones. I find it fun and enjoy it. Talk about it all at the end. But the thing about GLP-1s or anything with the health plan is this first criteria is just what does it cost? You have to remember that your health plan is a financial mechanism. Your health plan never made anybody healthy. Your health plan never made anybody sick. Your health plan never did anything to pay for things. You give you guidance on maybe directions you should go. Your health plan also might say whether it's medically necessary or not, and half of that medical necessity evaluation is money. The other half of it is real medical necessity. When insurance companies are talking about these things. So when it comes to these GLP-1s, why are we having a problem with them to begin with? What's the money? And one of the reasons we're having a problem was they first came out was the Hollywood drug. I'm getting ready to have my big show, I'm getting ready to get my wedding, and I want to lose 15 pounds, because you know I look so fat in my bikini that I've got to lose that 15 pounds before the wedding. And so you would take these drugs, very expensive, it was the weight loss drug of the wealthy. And they knew there was benefits to weight loss. But what's happening is we're kind of having this experiment on the American society. Albeit it might be a good one, but we're experimenting on Americans to say, if they start taking this, what happens? We're finding some very interesting, good things are happening. We're also finding there's some complications and difficulties. We'll talk about that. But the most important thing I want you to leave here with today is that there are actually ways to cover these drugs that become financially affordable for your members and for you, particularly if you're self-funded. If you're not, there's still some ways, I'll talk about that as well. But I'm going to talk about the social circumstances of it to a more extent, because you're looking at a person taking Wegovy. And yes, I'm still fat. Okay? So I started 4 months ago. And the first month was just, can I handle the drug? And the past 3 months have been to down, go up slowly. But I'm not doing it because I wanted to. I'm doing it because they're trying to give me and make recommendations to you. And they said, well, you do classify as obese. You're not morbidly obese. Your A1C is just below 6. That's really not great, but it's not diabetes. And so what we want to do is put you under the care of a professional organization that does this. Doesn't sell me the drug. It takes care of it. Their goal is for me to lose 1 pound per week. 1 pound per week. That's what any dietitian will tell you want to lose from diet or from exercise, is 1 pound per week, not 30 pounds in a month. So how you use this drug is also important. These are acquisition methods. I really don't want to go into a whole lot of this right now because in these methods, traditional PBM models, the AWP, wholesale price models, traditional and rebate models, negotiated formularies, and workers' compensation programs. Workers' compensation programs of drugs are always the most expensive. Anytime you can negotiate that platform, you want to do it, you do that before you can push. But those traditional models, the prices are still relatively in the same universe as what you saw on Terry's prior page. Way too much money. Okay? You can do it on a pass-through basis, but if I do it on a pass-through basis, what that I'm really cutting off is about, you're never really impacting the cost of these drugs for those bottles I just showed you by more than about 15 to 20%. But yet there's more, there's ways to get them cheaper. So all these different models that you would see, transparency, pass-through, seeing where the money goes. When you buy your drugs, any drug, whether it's Wegovy or any GLP-1, if you're doing business with the big three, which is CVS, Express Scripts, Caremark, you'll never know the real price of your drug. It doesn't exist in their universe. You only see the price they want you to pay. You never see the real price of the drug. That's the way the contract is written too. So they're not lying to you. You got it in the contract. As the contract says, that's what's going to happen. Okay, they told you to pay, and it's not the price of the drug. And other PBMs that are smaller also operate in that same premise. So you have to find PBMs that will do things on a pass-through basis. That doesn't solve the GLP-1 problem, but it would solve other drug problems. Specialty drug conundrum, period. Specialty drugs are expensive. They are rocking your health plans to the tune of making your pharmacy costs as much as 40% of your health plan or 45%. I've seen a 60%er where drugs were 60% of their health plan. Back when I first started in this business, we were astonished that 11% of our spend could be spent on drugs. Blair was back there back then. He wore his hair on top of his head back then. And my hair was auburn. Okay. But we remember those days, and the drugs weren't that expensive. So one of the things to do is to put in prior authorization programs. MSSC, the trust in Memphis that runs the schools that we work with, there are only 41 patients out of 6,000 members on GLP-1. Why? Because a very stringent pre-authorization program. And their drug costs have plummeted over the years, down 19% total over a decade. Down. Oh, sorry, more. However, that does cause a problem. What are they asking us to do? Mark, there's some good things about GLP-1s. And our people want them. They want to lose weight. So how can we cover them and not destroy our health plan? You want to go through programs, we have dedicated advocates, and you carve out the drugs to begin with, okay? I'm going to continue to talk about this more and plug in what we're saying here, because I don't go through the whole program before I go into more of a problem. But authorization programs, dedicated advocates, people that work with you while you're taking the drug. Every week, I have Joy call me. Joy is this beautiful person that's very kind to me, very nice to me, but she's one thing that we do not have in common, and that is she's not real. But this AI says, "Hi, Mark, how are you doing today?" And if I say anything more than fine or bad or good, then she has a problem. So she likes my short answers. And she asks me if I have any intestinal issues this week. Well, thank you, Joy, for asking. Of course I don't have intestinal issues this week. I'm taking Wegovy. So then also once a week I talk to a real physician. A live man, he calls me up, he's great, because when it's time for my appointment, I'm supposed to get online and see him face to face. He calls me up 2 minutes ahead of time and says, "I know you're a busy man, I don't want to keep you, so I'm just calling you up ahead of time, let's talk." And he asks me about what things going on, whether I should take more or not. And then once a month I talk to a dietitian. And I tell him, yes, I eat like crap, I know. All right, but I eat a lot less crap than I used to. All right? But that's a guided pathway. And then how we cover them through HSA or carve-outs is a different matter. I'm going to come back to that. It's almost 5 o'clock right now. And alternative sourcing. This gets to one of how we get them. All right. I'm going to talk just for a moment about specialty drugs, period, even though GLP-1 is a different classification. The federal government says that you are allowed to do this terrible, terrible thing to your health plan. It sounds terrible. In the end, it's kind of like a good thing. Where you can say, you know what, we don't cover specialty drugs. They're excluded from our health plan. And if you went out and told your employees that, you'd lose your freaking job. And in your room, they'd be in the chambers, everything like that. So you don't ever say something like that, or come on, don't ever say it like that. But you exclude the drugs from your health plan. But you're still going to cover them. Well, how is that possible? Because the feds also say they're allowed to have an alternative source to fund those drugs, separate from the health plan, called an HRA, a health reimbursement account. And we have told every single person at the MSSC Trust, which is all the school systems around Memphis, not Memphis itself, and they have said, they haven't told their people we don't cover, they just said in the plan document. What they've told their people is that if you put up with one phone call a year from a pharmacist and a physician, and it can happen at the same time, then we'll give you a drug for free. You what? You just for free? Yes. Because when it's not covered, the universe of drugs changes. There's what's called patient assistance programs. Patient assistance programs where the health plan, the manufacturer pays the drug. Out of that trust in Memphis, 20% of people taking specialty drugs, only 118 people were taking specialty drugs, and with a $4 million spend, actually higher. We said, we will give them to you for free. They said, all right, great. We like that idea. That's cool. One phone call a year, they got for free. That's right. 20% of those people got patient assistance. It didn't cost the health plan anything. It didn't cost the patient anything. The other half of those, the rest of those got coupons. So another 30% got coupons. Cuts the drug in half for a specialty drug. Then those who didn't get anything, we used a special procurement methodology, both international sourcing for the drug, which reduces the cost dramatically, and 340B pricing, which is what a hospital could sell it to you for on a 340B basis. And we're cutting that $4 million plus spend down to $800,000 for filling the gaps, so the number gets the drug. Same thing with Wegovy and these drugs. When you buy Wegovy directly from the manufacturer, it's $499. That's what they do. So when you exclude them, when you put an alternative sourcing method, you're cutting the cost anywhere from about $499 to $800 for these different drugs you saw there, these statins, other variations of the GLP-1's and the semaglutides and the other formations of those drugs. And all you need is a method, a caretaker, to make sure that the patient is doing their one phone call a year to get those situations done. And I believe we're going to have a method of that, and to do that if you wish, because I believe that the trust is going to open up its pharmacy that it has there to all of Tennessee. And you can get your specialty through their trust pharmacy and be able to obtain your drugs and put in that same program on a self-funded basis if you wanted to. So GLP-1s can be acquired for less in the manufacturers, and others are willing to sell them to you. Other formats of buying drugs are own use in 340B. I'm not going to go into that whole lot because we don't have really school systems in here, so own use is not relative. 340B, though, we just talked about how we buy it for less. Brick and mortar pharmacy, that's what Memphis has got. School systems down there. Their own brick and mortar pharmacy. In Tennessee, you cannot direct someone to buy a drug from a particular pharmacy. It's now against the law. So I can tell you, you have to go to get your Wegovy here. Unless it's not covered. Then I can say, well, the only place you go get it and pay for it is here. Okay? So you don't cover it. So I know it sounds crazy. Don't cover, but cover. Out of both sides of his mouth came those words at the same time. And it's just because you're doing what you're allowed to do. You just have to do it differently. Health plans beat up GLP-1s that don't like them, and who could blame them? But brick and mortar pharmacies are saying, when you have your own private brick and mortar pharmacy, you don't pay retail margin. You just cut retail margin on your drug. You don't pay a PBM margin. The PBM is that administrator that tells you what your drug costs when you go to the pharmacy, right? And you pay what's called the wholesale price. The wholesale price. Kind of like what Costco used to be. The wholesale price. And that's what you're getting at when you do that. So they've saved another $1 million, over $1 million, just by cutting out margins. And all the members want to go get their drugs there because that pharmacy, even though the health plan can't say your copay here is $0, every place else is $10. Health plan is not allowed to say that. But if you've gone to Kroger's enough or any other pharmacies, and all of a sudden, what was my copay? Oh, it was free. The pharmacy can decide not to collect the copay. Particularly when you own that on pharmacy to begin with. Why do I want to take it from a member? So ways to cover drugs, and these impact the way you can get Wegovy and weight loss drugs. Historical trend. This is really interesting, guys. The state of Tennessee plans going to blow up. And they're telling us it's going to blow up. The blue line is drugs. This is January 22. The green line is the average between drugs and the medical costs. The red line is medical costs. Drugs are going to explode in price. And even though we've got some very good intentions actions taking place in Washington regarding these drugs, they only are guaranteed to impact Medicare and Medicaid. They are not guaranteed to impact us. It takes legislation action to make them impact us. But then there would be all kinds of Supreme Court lawsuits on discriminating against businesses, kind of like when they broke up monopolies. It'd be crazy. So the state plan did not put in a program to take care of the people needing these drugs. Now I'm going to preach why. And you can see then the anti-obesity medication costs went up dramatically for the state of Tennessee. GLP-1s are first not liked because of their great expense. Now, I've just shown you a pathway to get around that expense, all right? In summary of the years and percentages with local and state active government plan change premium recommendations, this is what's going to happen to your plan on top of plan design changes for the state of Tennessee. You probably go on the state of getting that, or you can go online to see that and read what's happening there. Why are they having this problem? Is that because they just cover GLP-1s for weight loss and every physician in the world can prescribe it, and there is no maintenance of the individual? Type 2 diabetes. Most people live with that their whole lives, historically. Part of the reason they live with that is what's called the metformin curse. The metformin curse is cheap and takes care of balancing your A1C pretty well. But you'll have type 2 diabetes your entire life. The GLP-1, when used properly under guidance, not just your doctor prescribing it for you, and there are maintenance programs we can talk about more later afterwards. I don't want to talk about other companies and recommend things to you in this setting, but there are several organizations that maintain these. Their goal is to end type 2 diabetes. GLP-1s and other semaglutides and drugs similar to that, over a 36-month period, I found that type 2 diabetes can be reversed. And all those terrible things Terri was talking about, that can happen with your workers' comp plan because they have these problems and conditions, stuff like that. It addresses obesity, it addresses type 2 diabetes, and type 2 diabetes is a good excuse to get things covered in a rational way. All right? That's kind of like the silver bullet. And then morbidly obese is just as good. But then there's just me. I'm just fat. I'm not morbidly obese. My blood pressure could be better, and I could eat better. And my life would be better if I lost some weight. If anybody says that to me face to face, I'll have to. I just, okay. So that's the fact of life. So the way I do it is I'm doing it with the management, and I'm paying for the drug. Because I need to learn this because it's so important. But my life would be better because of it. And I'm on the pathway to losing 1 pound a week. I've lost 17 pounds. I know I look like it. I was a big boy. There's other strange things about GLP-1s and this great social experiment that we're finding out. We knew that it adjusted your production of insulin. We knew that it lined your gut and slowed the digestion of food. We're finding that the brain impact is greater than they thought it was to begin with. That it curbs certain desires. And there's one desire that doesn't curb, and I don't have to mention it, but you know what I'm talking about. but drinking, I drink less now. I eat less now. I have this one side effect that's kind of weird. I used to be fanatical about exercise. I still love exercise, I enjoy it, but I don't have this tick-tock going off in my head. When am I going to get to the gym? When am I going to exercise? When am I going to like it? It kind of dulls the major impulses that make you suddenly want to pick up a potato and go, and again, and again, and again, and again. So it impacts the impulse positions of the brain. And kind of like doesn't mute them, it just quiets. They call it quieting. They are researching this now for addicts. And what it can do, the anti-inflammation components of it are greater than they anticipated. And then it can also end up being a cancer treatment. Now they want it to be everything. They want it to be the miracle drug. Once they find it to do one thing, they want because their goal is to manufacture every miracle in the world on it. But what I'm trying to say is we do kind of have a new aspirin. Aspirin was a miracle drug. Massive anti-inflammatory. Not nullified pain. It's still used in very small doses in lots of the things you take because its nature is so strong. That may be what these GLP-1s are. Behavioral benefits, decreased schizophrenia, cardiovascular health, that the decrease in inflammation, which is the root cause of all of our major illnesses, may ultimately really be its best impact for us. The bad. Now, if I took every drug we talked about today, especially, and I put their side effects up there, there's a lot of drugs on a much longer list. But as someone on the drug, I can tell you the most common side effect is getting your bowels to regulate. So you got to take a lot of Metamucil or the other stuff or whatever to get those things to happen. And now I've kind of stable down. You know, it's all good. Other complications is some people feel nausea. My wife was a type 2 diabetic. And she had a heart problem. So her doctor said, you got to do GLP-1. She did the other one, the Ozempic. And my wife is down 55 pounds. And she looks like a freaking 30-year-old model, and she's 63 years old. I'm a happy man. She looks great, she's healthy, she feels good. Now she's having to do what's called their tridation, figure out how does she stop. She's been taking less. So now she's where her doctor's saying, lose no more, lose no more. So now we're trying to figure out how do we take her away from all this and keep the good thing happening. Her type 2 diabetes is completely reversed. Her cardiovascular issues have vanished. So wait, the drug is not the miracle, by the way. It's the food. It's the way you think. It's the way you act. It's the way you behave. Primary reasons is such a big deal. It's not that it necessarily will help everybody, because everybody sees it as hope. That my life would be different if I just took that drug. If you're miserable today, trust me, you'll be just as miserable tomorrow when you lose 60 or 50 pounds. Because your happiness never comes from your figure. An excuse to be unhappy might come from your figure. But your happiness lies in something else. So don't come to this drug, or anything you take, and say, this is the miracle drug, it's going to change my life. No, it's not. It's just going to change your appearance. It might make you healthier, maybe. It might help inflammation. So if anything, I was to say that the bad side of any drug is that we put more importance on it than the reality of changing our other habits in our life. When I'm taken off this daggone drug, and I'm going to be on it for 24 months, I'll be under physician care, but they already have a plan for me to move away from it. And if I need to be on something else for a little while, that's fine. But I won't be on this. In the meantime, it gives me from 24 to no more than 36 months to get this ticker under straight. And I do get the help of the drug diminishing what impacts me so much. So it does act like a bit of a good crutch. The cost problem with these drugs will alter in the future. They will change. And today you can get them a lot cheaper, and you just got to go to people that aren't interested in moving the drug around for money in order to get that done. We can help you with that. We're happy to. We're happy to help you with that, whether you work with us or not. And this is part of the social structure of our community, is that we have a pathway for you to address these things. You know, you don't have to sign a contract with me. You know, keep your local guy, just do this, whatever. So, you know, about 12% of the U.S. adult population have taken a GLP-1. That close to 32 million people. Currently, 6% of the U.S. adult population is using GLP-1s. 16 million people. Why do most people put GLP-1s? Two reasons. Most of them historically have been taking them without real, yes, they've been taking them for a medical reason, maybe by endocrinologist or something like that, but without real guidance of how to handle that drug and what it does to you. Is they stop taking it because for some people the side effects are more severe. For my wife, her side effects were definitely more severe. She went through a couple of weeks where she thought, is this worth it? I mean, she is not liking the nausea, she lost sleep until her body got used to it, and then she said, okay, I'm good. So many people stop taking it after the first 3 months. Everybody else stops taking it after about 6 to 8 months. Why? Because they lost the weight and they thought they solved the problem. that the drug is not bring happiness. Happiness is something you find here, and I think it goes this direction. But medications are extremely expensive in conjunction with risk management. Everybody needs to start thinking of their health plan as a risk management aspect of it. Because it's money, either way. And how you manage that money is a part of risk management. Even though you may not view it traditionally as a part of your risk management responsibilities, the financial situations in your health plan are important. MSSC Trust in Memphis has nothing but copay plans, no deductibles. A lot of their drugs are free. They haven't had a rate increase in 5 years. They're a self-funded plan, they have $24 million in reserve. And they spend about $60 million a year for 6,500 people. And no increases, a great plan, because what they do, they take every opportunity to step outside the box and do things differently. Their own pharmacy, their own clinics. Now, that's a big group, I get it. But still, that doesn't mean you can't collaborate, you still can't step outside the box, particularly in drugs. It's easy to step outside the box in drugs. And get your people's drugs free. As long as you got the big boys on Wall Street telling you how to do it, their number one job, I'm glad they do a job because they're in my pension plans, but is to help the shareholder. Other companies are in it for personal reasons. They're not only trading on Wall Street shareholder situations, but closely held companies like we are. So, type 2 diabetes management and weight management are going to continue to be with us. And using these drugs, I think, is a very good tool if used in the right way. And they're not going to be for everybody. But that's how you look at it, is in these two major risk categories of morbid obesity and type 2 diabetes. If you don't know this young man here, Terry will inform you. Any questions? Yes?
I know at one time these drugs were allowed to be compounded. Any chance that that will come back again?
It's compounding because there was a shortage of a lot of drugs, partly because of the supply chain issues from China and all that kind of stuff. They allowed compounding, and compounding was permitted, and it just ended. However, it's because there's no longer a shortage. The manufacturers don't want compounding to occur because it eats into their profits. So what has happened was several compounders bought all the supply they could possibly buy at one time, over a year's worth. So for about another year, for those who bought that supply before the deadline, you can still get compounds. But if you're being sold a compound program, it's a short-lived program. It'll end, unfortunately. But in the meantime, when I'm telling you get Wegovy for $4.99 directly through their pharmacy, shipped directly to your home, no signature required. All you have, that situation you have to be, they gotta have the credit to do it. But in that situation, what your plan to cover, it would just be a reimbursement situation with HRA, turning your bill and get your money. It's a little bit of work, but that's $490 and not $15,900. Yes, ma'am.
You may have said this, but what % of plans are covering these drugs?
The vast, I don't know exactly the percentage, but I can tell you that the vast majority are, because they were not perceived when they were first covered to be the issue they become. That's how the state got trapped in this. Even though there was a pre-authorization methodology to it, it wasn't a very stringent one. It's just, are you a type 2 diabetic? If you are, then take this drug. And boom, it exploded. Now, remember that even though I would say, if you can guarantee yourself that even at $15,000 a year, that person is only going to be on Wegovy for 24 months, and then they get off of it, I would say, build a bank with money short term and take the deal. Because that person will be worth will cost you a lot more money over their 20 to 30 year career than that 24-month period. And I don't want you to pay that price for that drug. I'm saying that's where you have to start doing the math. Like I said, metformin, the worst curse you could ever have for a type 2 diabetic. I'll never leave it, never leave it. Any questions? All right, thank you very much, guys. and then we'll